I'm Lennel Lutchman. I'm a consultant spinal surgeon at the Norfolk and Norwich Hospital, and we're in Norwich to discuss the case that I posted on the Author Hub website of a 17-year-old young man, high energy trauma, burst fracture of C5 with an incomplete spinal cord injury. We want to talk about the diagnosis, the clinic, both on the history and the examinations. We want to talk about the surgery, the timing of the surgery, which procedure, and finally talk about the prognosis. I'm on Bishop Bridge in Norwich, which is believed to be one of the oldest bridges in England to still be usable. I enjoyed the way Lee and Graham, my neighbours in Cambridgeshire, used the mathematical bridge as a basis to discuss the scientific side of orthopedic surgery. I'm going to take a more artistic approach, and to answer the questions that we raised, we're going to go on a short literary tour of Norwich. We start our literary tour of Norwich here at Dragon's Hall, which is a 15th century merchant's hall, so called because of 14 dragons carved into the archways. It's said to be made of 1,000 English oaks and now serves as the National Centre for Writing. It involves a 17-year-old young man who has a burst fracture of C5. He has a high energy trauma having been knocked off his bicycle, and he presents with what we know is an incomplete spinal cord injury. We know that because he's got preservation of sacral function. The question is, what's the level of the injury? He has not got a normal deltoid or biceps function. In fact, he's got a flicker of movement. The ASIA chart, the ASIA's classification system, defines the level of the injury, the motor level, as the last level below the level of the injury that has grade 3 power or more. So he therefore can't have a C5 lesion, it has to be C4. Had he preserved deltoid and biceps at grade 3 or more, that would define it as a C5 level. But in the absence of that, it's therefore a C4 incomplete lesion. The question I asked you was, could you define the mechanism of injury? The classic orthopedic mechanistic classification is Loger-Hansen's ankle classification, I guess you would say. And the analogous classification for spinal column injuries is Allen and Ferguson's 1982 classification. And I suggest you look that up. It's a good paper to read, and it really focuses on the mechanism of spinal column injury. And by that classification, this is a flexion compression type mechanism. Third question is a giveaway. We've discussed this in the lecture. The only thing that you can answer for this is CT scan. This young man has a high energy trauma with a suspected spinal cord injury, and he needs a CT scan. In the 16th century, Norwich was the second largest city in the country, and its wealth was built on its wool trade. That wealth went into building many of the churches for which Norwich is famous, including this church, which is St. Julian's. Julian was born in 1342 in Norwich and became an anchoress. She spent many decades living in this cell, which is attached to the church that now bears her name. She is quoted in T.S. Eliot's Little Gidding, his famous poem, in which he quotes, "All shall be well, and all shall be well, and all manner of things shall be well," which predates Bob Marley's "Every Little Thing's Gonna Be Alright." Whilst in the cell, Julian wrote Revelations of Divine Love, which is said to be the first book written by a woman to be written in the English language, and may be the longest surviving book of any sort to be written in English. Question 4 was the surgical priority. The priority here has to be decompression of the spinal canal, so removal of the C5 vertebral body via corpectomy. This question doesn't really have a correct answer. I just wanted to get you thinking. The priority is decompression, but of course it makes sense at the same sitting to stabilize the spine. So I think the best answer would probably be decompression and stabilization, but there's no correct answer for this. The fifth question had to do with the timing of surgery, when to operate. This is a young man with a high energy trauma, which is incomplete, and one could argue that you should operate immediately, and certainly I operated on him at 3 o'clock in the morning. There might be a case to be made for putting him in traction, in tongs to reduce the dislocation, to realign the spinal canal, and to come back on another day to stabilize the spine first thing the following morning. But it's reasonable to say here that immediate operation would be the option of choice. And the final question was to do with what procedure, anterior, posterior, circumferential. For me, the best answer is circumferential, an initial anterior approach, decompression, stabilization, and a staged second procedure coming back to the posterior approach and stabilization on another day. So we conclude our literary tour of Norwich here on the campus of the University of East Anglia. Norwich was the 2012 City of Literature, and there's a great history of literature in Norwich. Behind me is the Sainsbury Centre, which was built in 1978 and designed by Sir Norman Foster. And in the distance are the ziggurats, another iconic architectural feature of the University of East Anglia, which is the student residential accommodation. The last question had to do with the patient's likelihood of recovery of neurological function. The main determinants are his age, the level of the injury, and the severity of the injury, whether it's complete or incomplete. There are various references which I'll post regarding the prognosis for recovery, but there's little doubt that the main determinant is the initial insult, the severity of the injury, and the primary injury. The things that we can modify are the secondary insults, avoiding hypoxia, avoiding hypotension, and decompression of the spinal canal and stabilization of the spine. These are explored in many studies, many of which are, if I'm honest, methodologically flawed. The status study is often cited, but that's got its own problems. I can't say if this kid's got a 5% chance of recovery or a 75% chance of recovery. This question was just merely to get you thinking and to get you thinking about the chances of neurological recovery. I'd probably put it at 50-50. I remember at the time saying to his mum that if I was a betting man, I was very worried that he might not walk again. And I was pleased 9 months later to get a letter from his mum saying that he not only was walking, but he was making great steps to a almost full recovery. So it just goes to show that it's not always possible to determine how patients are going to do after spinal cord. So that includes our literary tour of Norwich. I hope you've enjoyed it. I hope you've learned something about literature, but more importantly, I've hoped you've learned something about spinal surgery. The University of East Anglia is pretty famous. Its Masters of the Arts in Creative Writing is one of the most famous literature courses in England, and it was established in 1970 by Malcolm Bradbury. Alumni include Kazuo Ishiguro, who won the 2017 Nobel Prize for Literature. Finally, as a parting shot, if you enjoy literature, this is a great work of historical fiction. It's called The Devil's Die, and it's by Jenny Neal, who's a Norwich author, who just so happens to be my wife. Thank you very much for inviting me to contribute to Author Hub, and I hope to be invited back sometime. Thank you very much.